Welcome to the Explainer. So, today I want you to grab your metaphorical magnifying glass and step into the shoes of a medical detective. We're about to investigate literally one of the most notoriously complex and technically demanding areas in the entire medical coding profession, Vascular Interventional Radiology, or IR coding. It's a field where one missing detail, just one tiny clue, can completely unravel a case, leading to painful denials or lost revenue. But don't worry, we're going to crack this case wide open together. Okay, let's dive into this. Here is the roadmap for our investigation today. First, we'll look at the IR coding challenge. Then we'll translate the terminology and face the diagnostic dilemma. From there, we'll uncover the golden rule of IR coding, investigate supply coding and HCPCS, and wrap things up with best practices for compliance. All right, Section 1, the IR coding challenge, high stakes and hidden clues. Vascular IR coding sits right at the center of complexity because, quite frankly, the stakes are incredibly high. Missing a single clue in a procedure report? Well, it doesn't just mean a typo. It leads directly to audits, claim denials, or improperly lost revenue. It's a specialty that demands absolute precision. And to crack these cases accurately, a coder can't just know one rulebook. Mastery requires combining 4 distinct areas of expertise into one cohesive investigation. You need a rock-solid grasp of vascular anatomy. You've got to navigate complex CPT guidelines. You must apply National Correct Coding Initiative, or NCCI edits, and you absolutely have to understand HCPCS Level 2 supply coding. I mean, if you're missing any one of these 4 pillars, your entire case just falls apart.
Moving on to Section 2, translating the terminology, the clues.
Before we even think about diving into code selection, we have to establish the basic facts and the specific terminology hidden within the physician's operative report, right? Without the right vocabulary, we just can't translate the evidence. So let's start with the absolute foundation. What does vascular actually mean? Well, it pertains to vessels, particularly blood vessels, or an area having a copious blood supply. This sets the strict anatomical boundary for our entire vessel-specific investigation today.
Next up is the word patent. And no, not the legal kind. In this context, it simply means open, unobstructed, or not closed. Now you might be wondering, why does a simple word like this really matter? Because physician documentation frequently uses these exact words to describe the status of a vessel, the procedural findings, and patient outcomes. And those specific details, they directly influence which CPT codes and modifiers are appropriate to use on your claim.
Depending on the clinical indication and the target anatomy, vascular IR procedures require access into one of 3 routes: an artery, a vein, or the lymphatic system. Finding this specific clue in the report is critical. Identifying the exact access site and vessel type determines which catheterization codes apply, whether the procedure is coded as arterial or venous, and honestly, whether vascular access and closure are even separately reportable in the first place.
Which brings us to Section 3, the diagnostic dilemma, the interrogation.
We are now going to tackle arguably the most common source of confusion in this entire specialty. The big question literally every coder faces: diagnostic or therapeutic? Can you code both? Like, if a diagnostic angiogram is performed at the exact same session as a therapeutic interventional procedure, can they coexist on the same claim? The short answer, it depends entirely on the scenario.
Now, what's really interesting about this is how CPT guidelines cleanly separate this dilemma into 3 possible outcomes. First up, you have separately codable diagnostic angiography. This usually happens when a diagnostic study wasn't previously available, was maybe for a different indication, or led directly to the decision to intervene. Second, you have bundled diagnostic angiography. This is where the diagnostic study is always included in the therapeutic code, no matter what the documentation says. And third, situational catheterization coding, which depends entirely on specific CPT guidelines and payer policy. You absolutely cannot rely on memory here. You have to check the rules for each specific procedure.
And you know, this dilemma extends to imaging guidance for vascular access too, like using an ultrasound for a needle placement. Sometimes it's separately codable, and sometimes it's bundled right into the primary procedure. As an expert coder, you have to interrogate the specific CPT code descriptors and the current NCCI edits to see if those guidance codes can be reported in addition to the primary intervention.
Section 4. The golden rule, the smoking gun.
So, the crucial point in your investigation, the real turning point, is this. Read the entire operative report, from start to finish. Accurate IR coding relies on precise physician documentation, for sure, but it depends equally on a thorough review by the coder. A procedure header or an impression list, honestly, that is often an incomplete truth. You can never, ever assign codes based solely on those summaries.
You really have to read the body of the report because that is where the vital details are buried. We're talking details like the exact vessel accessed, the catheter selection order, contrast injections, vessel-specific findings, and the medical necessity for every single step. For instance, whether a diagnostic study actually changed the treatment plan, that's a detail usually hidden deep in the text. Physicians need to dictate these details and coders need to find them so the codes can be correctly assigned and completely defended in the event of an audit.
All right, Section 5, Supply Coding and HCPCS, the evidence room.
Aside from the procedure itself, we have to account for the physical evidence of the case, the drugs, the devices, the stents, and the catheters used during the intervention. But who reports these supply codes? Well, it completely depends on the facility type. Outpatient hospital departments report most vascular device codes using HCPCS C codes. Even though they are generally packaged and not separately paid, hospitals must report them because CMS uses this claims data for future rate setting. Accurate charge capture here literally ensures the specialty's future reimbursement. On the flip side, non-hospital facilities, like physician offices, generally do not separately bill for these supplies. Why? Because CMS has already built these costs into the practice expense component of their relative value units, or RVUs.
And this brilliantly illustrates the types of physical evidence documented in an outpatient setting. You'll encounter a variety of HCPCS C codes. For example, you've got C1725 for an angioplastic catheter, C1769 for a guide wire, C1874 for a covered stent, and C1880 for a vena cava filter. But remember, this is just physical evidence from a specific moment in time. Actually, you should always consult the current year HCPCS codebook because these codes and descriptors update annually.
Finally, Section 6, Best Practices for Compliance, Case Closed.
Let's bring it all together and see how this builds your final defense. To reduce denials and withstand strict audit scrutiny, you want to follow these core steps. First, always read the complete operative report, not just the header. Second, confirm the exact access site and vessel type before selecting catheterization codes. Third, verify those diagnostic versus therapeutic rules and NCCI edits for your specific procedure. Fourth, assign applicable HCPCS C codes based strictly on your facility type for rate setting purposes. And finally, stay current with annual CPT and HCPCS updates because, let's face it, the rules of the game change frequently.
Mastering vascular interventional radiology coding is about so much more than just matching a procedure name to a CPT code. It demands true detective work. You have to understand bundling rules, diagnostic guidelines, and supply codes based on your exact site of service. So I leave you with this final, vital question. Are your coding practices actually audit-ready? Take these detective skills, apply them to your next case, and make absolutely sure your documentation and coding can stand up to the highest level of scrutiny. Thanks for joining me on this explainer, and happy investigating!